Rodgers. I'm a clinical dietitian. I work at MD Anderson, which is a large cancer hospital in Texas, Houston, Texas. I want to thank you for allowing me to talk to you today, and hopefully you'll get some good information that you can use out of this talk. So we are going to have three different sections. We're going to have a section where we talk about malnutrition, a section where we talk about basic nutrition assessment, and then what nutrition intervention might be appropriate for your patients. So our first section we have subcategories. We're going to talk a little bit about prevalence, consequences, and high-risk populations. What percentage of patients who have malnutrition upon diagnosis? The answer is 15 to 40%. So unfortunately, before we even see a patient, a lot of times they come in malnourished, especially patients that may need radiation treatment. Head and neck patients, lung patients are going to be a really high risk group, GI cancers too as well. So why do we talk about malnutrition? And basically, it's because the prevalence is really high in patients who have cancer. There's many studies that have been done that show that malnutrition is very prevalent in the population. Upon diagnosis, it can be 15 to 40%. And during treatment, it can increase even more to 40 to 80%. So we really talk about malnutrition so much because it is prevalent. And what are the consequences of malnutrition and cancer? You have a decreased quality of life. If you lose all your muscle, you're weak. You may have to go into the hospital more. This can delay your treatment. Also, too, if you become really malnourished and you get through your treatment and you're on the road to recovery, it's a much longer recovery. It's going to take you even longer to heal, especially from a treatment of a head and neck cancer with radiation treatment. It takes those patients really a long time to heal after their treatment. You may have muscle loss, which increases your fatigue. You may need interventions like getting IV fluids for hydration, or even if you're not able to eat very much at all, you might need to get a tube placed to give yourself enteral nutrition or a tube feeding. And unfortunately, we know too with cancer, you have a decreased survival rate when it comes to malnutrition and cancer. It's one of those things that it's a little bit of a slippery slope. Once the patient starts to lose a little bit of weight, they're in a disease state where it's an inflammatory place that they're in. And then once it gets to the point where you see like a cancer cachexia, you can almost not recover from that at all. So we really want to try to be pro-nutrition when the patient first comes in. So a patient may come in and they may think, oh, I need to lose a little bit of weight anyways, or they may think it's not going to be that bad, or they may think that I can make up for it, but really stressing at the first intervention that you have with that patient, how much it is important for them to maintain their nutrition status. And we're not just talking about weight in general, we're really talking about lean muscle mass, because unfortunately, when we lose weight really fast, we almost always lose our muscle mass. The body's going to go find energy somewhere, and it goes to our muscles and completely depletes them. So high-risk populations for malnutrition can be head and neck, up to 70% of those patients, lung patients, 20 to 45%, GI, 20 to 70%, depending on the type of GI cancer. Obviously, esophageal cancer is going to be much higher than like a colon cancer. Gynecological cancers can be high risk too as well. They may have a tumor burden that makes it a little bit more difficult for them to eat because their belly is swollen. And bladder cancer too, just basically because sometimes these patients have a lot of pain, irritation, and they may not want to eat if they feel like they're going to have to urinate a lot. So this can be really high risk population too as well. So it's important to make sure that we are going through different types of things. And this is section 2. So we're going to talk a little bit about like, how do we discover whether or not a patient may be at risk for malnutrition and may need some intervention. There's some malnutrition screening tools, which we'll talk about. We'll talk about anthropometrics a little bit, diet history, nutrition-focused physical assessment, laboratory values, and estimating needs for our patients going through treatment. So what percentage of patients develop malnutrition during treatment? We kind of said this a little bit before, 40 to 80%, very high. So there's different forms of malnutrition screening tools. And basically, as nurses, this is the first line of defense for patients. A lot of times when you're going in, just asking a few simple questions to the patients can really assess whether or not they're at risk for malnutrition. Different tools could be the Malnutrition Universal Screening Tool or MUST, Mini Nutritional Assessment, MNA, Nutrition Risk Score 202, and malnutrition screening tool. So basically, these are different screening tools, and they're asking a variety of different types of questions. But the majority of what you're asking the patient is, hey, are you not eating as well? Are you not able to eat as much as you usually do? Some of them say, are you taking nutritional shakes? And then also too, they're looking at the percentage of weight loss in the patient too, which can really be a good indicator of malnutrition in that patient or a risk factor for malnutrition. We don't want to wait till they're malnourished. We want to be a little bit proactive and making sure that we keep them as nourished as possible. So anthropometrics is height, weight. You want to consider fluid shifts. Sometimes a patient may lose 5, 6, 7, 8 pounds in a week. That's not fat or muscle, that's fluid loss. Maybe they're having trouble taking in fluids. Maybe a little bit of IV hydration can help them out a little bit during their treatment. BMI is, again, a screening factor. Very severely underweight would be a BMI less than 15. Severely underweight could be 15 to 16. Underweight could be 15 to 16 to 18.5. Normal weight is 18.5 to 25. Obese or overweight is 25 or above 30. Now, you want to consider BMI, again, as a screening factor. If you have a person who comes in with a large muscle mass and a lower fat mass, their BMI may be in the obese range, but we don't consider that to be obesity. It's just a screening tool that you need to use. So what is considered significant weight loss? Basically, weight loss of 2% loss in 2 weeks, especially these patients going under head and neck radiation treatment. They're going to be a really high risk group. 5% loss in 1 month, 7.5% loss in 3 months, 20% loss in about a year. If their BMI is less than 18.5 or they're less than 90% of their ideal body weight. These are all significant weight loss or weight loss risk factors. Some things you might want to be asking the patient, are they eating less than 50% of what they normally eat or 75% of what they normally eat? These are going to be high risk factors for malnutrition. You want to see if they're having any nausea, vomiting, diarrhea, anything that may get in the way of their ability to eat. In addition, they may have painful swallowing with their treatment, or they may just have trouble swallowing in general because of their disease. Whether or not it's like a head and neck cancer, sometimes they can have just an obstruction from their head and neck cancer, or sometimes even lung cancer. You see that too. Maybe they have a tumor burden that is pressing in on their esophagus and they can have some trouble swallowing. You want to look to see if anybody has any trouble chewing. Patients may have dry mouth. They may have altered taste. They may not have any other side effect other than altered taste, and they lose weight just because the food tastes bad. They cannot get past it. It's really difficult for them. And you may want to also ask, are you skipping meals? So some people, they may normally eat 3 meals a day, and some people may eat 2 meals a day. It's just depending on what that person does. So if they're normal, a 2-day person meal, and those meals have decreased by 50%, you can pretty much think this is going to be a high risk patient. Okay, next, nutrition-focused physical assessment. We can tell a lot from a physical assessment in a patient. So maybe the patient may not be showing overt signs of malnutrition, but we can really look at muscle and fat loss too in those patients. So things you want to look at that are really easy to observe. One is like temporal wasting, where you kind of look into the person. Sometimes people just normally they have a little bit of an indention there, and that's just how they are in general. We're not talking about that, but get your hand down in there, feeling that muscle. If you chew, you can feel the muscle more. And so if the person is really malnourished, you will see that go indented. It'll be fairly indented here. If you look in the eyes and the eyes are really sunken, that's an indicator of fat loss. You can see that it's easy, or you may see it in the cheeks too, right here. That may be fat loss as well. If you're looking at a patient and you're looking in their shoulder area and the clavicle is really, really evident on the patient, you can push down too as well. And you're going to see some muscle loss in that patient. And it may even just look really sunken in. As well as you may just come up to your patient and put your hand on their shoulder to see if you can feel their bones, to see if this area too is really decreased as well. Other good signs too is if you get the person to make like an okay sign, and you wanted to get them to really press down on that okay sign. And we're looking at that muscle area right here. You're going to kind of want to press in on it, and you'll see on a malnourished patient that muscle right there, it's almost very visible that the muscle may be all the way up here. So it's a really good tool that you can use to see if a patient has lost some muscle. You also want to look at their teeth. Are they going to have any trouble chewing? Look at their tongue. These patients are going to be at risk for thrush or other like bacterial infections. They may have mouth sores in there that you need to treat that can help them to eat. And look in their skin and hair. If their hair is really dry and easily pluckable, this can be signs of malnutrition too as well. Okay, laboratory values. If you have those available to you, really good laboratory values that can really show us hydration status are BUN or creatinine level, and also the sodium level. If the sodium level's gone low, they're probably a little bit overhydration. Sometimes in these patients too, you can see where they actually may be losing more sodium. They may not be overhydrated, but they're just losing a little bit more sodium. That level may go down, but creatinine levels are going to be very sensitive to hydration issues. You also want to consider the fact if someone has not eaten for a long time, they're going to be at risk for refeeding syndrome. So say during a treatment, you are not able to get the patient to eat very much and they lose 20% of their body weight, which happens. Sometimes it can be more on that, especially if you have a tiny little lady that maybe weighed 39 kilos to start. She may lose half of her body weight if she's really having trouble eating. Refeeding syndrome is basically when you start to feed the patient again, especially carbohydrate. And what happens is your body is really trying to make those energy stores again, and it needs phosphorus to do that. And you have completely become deficient in phosphorus. And when you start to refeed carbohydrate, phosphorus goes down really low. Typically, your magnesium and your potassium levels will shift too as well. And this can actually cause death in the patient. So what you want to do in a patient who, say, is at risk for refeeding syndrome, when you start to refeed that patient, you want to go a little bit slow, especially with carbohydrate. So say, for an example, if you start to get a patient to take some nutritional protein drinks with carbohydrate in it, you may want to just start with one drink a day. Okay. And then the next day, go up to 1.5 drinks today. And the third day, go up to 2 drinks a day. If you go a little bit slower with that high carbohydrate intake, you can decrease your risk for refeeding syndrome. In addition, you can supplement thiamine too as well, 100 milligrams daily, and this can help decrease your risk for refeeding syndrome as well. You may also have patients who have blood glucose levels, especially if a patient is getting like chemo rad, where they may be getting steroids with their chemotherapy. They may have a side effect of hyperglycemia with that. And of course, there you're going to want to look at symptoms of elevated blood sugar, which can be extreme thirst, extreme hunger, sleepiness, and you have to urinate a lot. Next slide, estimating needs. Okay, this is really complicated. I'm just kidding. That's my joke slide. That's my dietitian joke slide. Estimating needs during radiation, you're going to want to think they need a lot of calories and they need protein. Mifflin St. Jeor is a predictive equation. I've given the numbers here too as well. It's proven in cancer patients, but you want to make sure that you're using an activity level from 1.2 to 1.4 because their needs are going to be really high during radiation treatment. This table down here is just like a standard general guide of what you may want to look at if you don't want to do the Mifflin St. Jeor equation, which is fine to do. If you have a person who's not really losing weight at all, they may need 20 to 30 calories per kilogram per day, and this is on their current body weight. If they're malnourished, they may have maybe 35 to 40 calories per kilogram per day. Of course, if those patients are at risk for refeeding syndrome, we want to start a little bit lower, 15 to 25 calories per day, whether they're malnourished or not malnourished. Protein needs are also very high too as well. You want to give at least 1.2 to 1.4 grams per day. If the patient's really catabolic or they become malnourished, it can go up to 1.5 to 2.5 grams per day. The only thing you need to consider is if a patient is obese, you want to use their ideal body weight and not use their current body weight. Otherwise, if you have a 200 kilopound person and you're not using their ideal body weight, obviously it's going to be really hard to get that much protein in somebody, and they don't need that much. Fluid can be 25 to 35 milliliters per kilogram. Fluid needs too, I find when they're going through radiation, they need a lot of fluid, even higher than this sometimes. A good thing to talk to them about is looking at their urine output. If a person's overhydrated, their urine is going to look clear. There's going to be no color to it. If they're perfectly hydrated, it's going to be a pale yellow. If they are underhydrated, it's going to be a little bit more dark and concentrated. The next slide, this is like a general slide, but this is for a patient kind of not going through radiation treatments. So general energy needs are on this slide too as well for male and female. Signs of a deficiency in energy, they may be tired, not able to do as much as they normally do. Aging can be a little bit tricky, especially on those nutrition-focused physical assessment. They may have sunken stores just because they're older person. Signs of protein can be weakness. Again, we talked about our hair changes. Fluids, again, another good example is they may have orthostatic hypotension, where they stand up and they get dizzy because they don't have enough hydration in there. Fiber, sometimes patients can be really constipated when it comes to taking pain medications during these radiation treatments. You'll be lucky if you get 30 to 38 grams of fiber in them. A lot of times if they're on pain medication, you do need to give them stool softeners just to help them go to the bathroom. And I usually don't recommend giving vitamin or mineral supplements unless there's a deficiency during treatment, and we'll talk about that in a few slides. Okay, section number 3, we're going to kind of really talk about what are we going to do with our patients when they're at risk for malnutrition. populations that might require more interventions than other, side effects management, avoiding antioxidants, increasing oral intake, and we're going to talk about enteral nutrition too as well. Okay, what percentage of weight loss decreases survival? 2 to 5%. It's been shown in lung patients as much as 2% weight loss. And that's really unfortunate because a lot of times patients, before they've even come to see us, they've already had a percentage of weight loss. But again, all these questions are just really to keep our eye focused on. We really want to focus on nutrition during their treatment because sometimes patients aren't thinking about it. They're just thinking about trying to get through the next day. It needs to be a forefront in them. They're not going to feel like eating. So really focusing on that with them. Where might there be the most intervention in radiation treatment? Head and neck cancers, definitely. You'll be surprised. Some head and neck cancers, they go through it and they're just fine. They don't have any issues. It's really a weird thing. They didn't even have that much pain. But a lot of times they will have mouth sores, dry mouth, definitely altered taste, even brain radiation. When a patient gets brain radiation, they'll have really terrible taste buds. They may have mucositis or esophagitis where it's really painful swallowing, and they may have a really dry mouth, or most of the time they do, where it's just then very difficult to eat because your mouth is so dry. Thoracic, depending on where you're being hit. If you're being hit, if you have a tumor burden, obviously you may have some trouble swallowing. But if you're being hit a little bit in closer to your esophagus, you may have some esophagitis there with thoracic patients, or a myeloma patient, all of those sort of things. Gastrointestinal, obviously, they may have a risk for malnutrition, but they may have more gas and bloating with treatment. They may just have more pain with eating, depending on the type of gastrointestinal cancer. Colorectal, you may have more irritation down there, that the patient has more loose stools because they're being irradiated down there. So that may be the intervention that you're doing with them. Same goes with gynecological patients. When they're getting radiation down there, their colon's down there too. So a lot of times the irritation can happen down there too as well. Same thing happens with some prostate patients, especially if they're having their lymph nodes hit, they can become even more irradiated down there. Your colon is just not happy with you. You're having a lot of loose stools. And breast cancer too is kind of like thoracic. If they're being hit on the inner part of their breast and the field is wide, they may have some esophagitis too. However, most breast patients don't need any nutrition intervention, but it does happen sometimes. Okay, what side effects may they be feeling? Fatigue, what do we do with that? We concentrate on making sure they're getting protein and calories. We're telling the patient, alternate rest with activity. Don't just sleep all day long. This is going to be a little bit worse for you. Make sure you're getting plenty of hydration. Nausea, make sure that you are taking your anti-nausea medicine if you have that available to you. If you don't have any mouth sores or anything like that, you're going to do a little bit better with bitter and tart type foods like lemon or oranges or things like that. If you have irritation in your mouth or mouth sores, you don't want to eat something that acidic because it's going to hurt when you eat it. Avoiding greasy, fatty foods, high fiber foods can sometimes make nausea worse. Pain, it's really important to make sure you have pain management on board. What I find with the head and neck patients is, like, a lot of times they will have to take their pain medication and they'll have to have some sort of viscous lidocaine or magic mouthwash where they are just taking that before they eat. Sometimes it's just one sore where they take the viscous lidocaine and they put it on there and really deaden that one spot so where they can get their nutrition in. But a lot of times you have the combination of those two because the pain can be so difficult for those patients. And keep in mind, pain medication, anti-nausea medication, those are both constipating medications. A lot of times they take They need to take some sort of stool softener to help them go to the bathroom, because if the patient becomes constipated, they're not going to eat. You have to get upon all of those factors to get them to eat a little bit better. Gas, you may have more gas during your treatment too as well. You can take some methicone or gas X a couple of times a day, and you want to avoid foods that are going to be high in gas. Any sort of carbonated beverage is going to cause a lot of gas. Drinking with straws causes more gas. Certain foods are gassy, like raw fruits and vegetables are going to be a little bit more gassy. Cabbage, Brussels sprouts, asparagus, beans or legumes, those are just more gassy food. Sometimes patients have a little bit more trouble with lactose during that time, which can be really gassy too as well. Diarrhea, again, we're talking about those patients that may be irritated, prostate, colorectal, gynecological cancers may have more irritation as they go through their treatment, and they may be having more diarrhea. A lot of times they have to take anti-diarrheal medications to help out with this. You want to make sure that they're replacing their fluids. Sometimes you can give them an oral rehydration solution, which just helps them to absorb that fluid a little bit more. An example of an oral hydration solution would be like a Pedialyte. The World Health Organization also has a recipe for an oral rehydration solution, where basically you're taking like water with a little bit of juice and putting a little bit of salt in it. Just you rehydrate a little bit better with the solutions like that. You, of course, want to avoid greasy, fatty foods. It'll make your diarrhea worse, and high fiber foods will make it worse too. So really eating low fiber when you're having diarrhea is going to be important. Esophagitis is the same as if you have mouth sores, utilizing that pain medicine along with the oral pain medicine just to get the foods down. You want to use softer, more moist foods that aren't irritating to the person, avoiding any kind of spice or acidity that's going to hurt them more. Sometimes really cold foods bother them, or really hot foods. When they hit those sores, it can be jarring to them. So trying to get room temperature foods, that's really important. Loss of appetite, going to smaller, more frequent meals, making sure that you have a protein source there, softer, more moist, and you have an energy source there, whether it's fat or carbohydrate. Dry mouth, using baking soda rinses can help with your dry mouth, which is basically 1/4 teaspoon of baking soda in 4 ounces of fluid, or you can do a half in 8 ounces. You basically mix that up in the day. It can help with mouth sores too as well in the healing. You just swish it in your mouth and spit it out. You can do it 6, 7, 8 times a day. That can help too with dry mouth. If they have the ability to use a cool mist humidifier at night when they're sleeping, that can help with their dry mouth too. Sucking on hard candies can help with that. Another thing that helps too is if you get a little bit of coconut oil and you use a little bit of warm water, melt that coconut oil, swish it around and swallow it. It helps with dry mouth too, and you get a little bit of extra calories with that as well. Dysphagia or painful swallowing, softer, more moist type foods, again, avoiding those acidic foods. Altered taste and smell. This is the most unfortunate. The pain and everything is terrible, but altered taste and smell lasts for a long time. People become very disappointed in the fact that their food does not taste the way that it should taste, or it tastes terrible. Especially with brain radiation, it just tastes terrible to them and they cannot get past it. But they can't go 6 to 8 to 12 months without eating. So it's really encouraging that patient to get past it, thinking of food more as fuel, using softer, more moist type foods that literally don't stay on the taste buds as possible. As long as they don't have mouth sores or anything like that, you can use a straw and kind of bypass the taste buds a little bit, or just drink a protein shake down, just something to get the nutrition in. And something that I tell my patients a lot of times is think about food in a different way. If you don't put gas in the car is not going to go. Okay. So you may not feel good the day that you're eating it, but tomorrow you're going to have more energy. You're going to feel better. Instead of how we think about food now, we think about food as being very pleasurable. It's healing, that sort of thing. And it's not pleasurable to them when their taste buds are off. It's really difficult to get past that. Sometimes thrush is a cause, making sure they don't have thrush or that it's treated, or other bacterial infections can make it worse. But this lasts longer than anything. And then sometimes it lasts for a lifetime, unfortunately, on these patients who have head and neck cancers. So really teaching them another way to eat. Mucositis, we went over the things to do, the pain medicine, softer, more moist foods, the dry mouth. I put it there twice. I didn't realize I did that. But again, softer, more moist foods. Thick secretions. This is also very difficult for the patient. Sometimes more textured food, or even a beverage that's more texture, it gets caught on the food. And if they have a hypersensitive gag reflux, they can't get past that. So really trying to thin those secretions as much as possible. Sometimes they give medications to help thin them. If you take like a diet ginger ale, let it go completely flat, and you swish it in your mouth and swallow it, it helps to thin those secretions. But just make sure there's no carbonation in there at all. You let it get really flat, and you need to use the diet version. It works better than the regular version. Making sure they're really hydrated so they thin out those mucous membranes, but this can be really difficult for the patient. And of course, we talked about constipation. If the person's on pain medicine or anti-nausea medicine, you can do some things with food, like you can take 4 ounces of prune juice and warm it up, and it can help. But a lot of times they have to be on a stool softener because the medicines are so constipating. So those are really the biggest things you will see as side effects that impact their nutrition from them. So I wanted to go a little bit more in detail on this slide. Okay, avoiding antioxidants. The study, a lot of times when you have patients come in and they have cancer, they want to take vitamins and minerals. They're really excited about it. They want to do everything they can to kind of heal themselves. The studies are controversial and there's mixed results with that, but typically we tell patients to avoid supplements during treatment, especially antioxidants during radiation treatment. There's actually been shown that it may have a protective effect on the cancer cells too as well. So your radiation isn't quite working as well because you're protecting those cancer cells too as well. There are no studies that show high antioxidant foods do this too as well. So I tend to try to encourage a person who really wants to help themselves to get those from fruits and vegetables that are high in there. Now, during radiation treatment, they may not even be able to eat these foods either. So it's just really important to make sure that they're getting high protein, high calorie foods in at that time because it's so difficult for them to eat. Increasing oral intake. How do we do this? Smaller, more frequent meals. Making sure you're pairing a carbohydrate or a fat with a protein. We want to use the protein for muscle. So you can't just eat protein. You have to eat both. Ultimately, what you're trying to do is use the fat and the carbohydrate for energy and the protein for your muscle. Softer, more moist foods. Utilizing those pain medicines so we can get the nutrition in. Adding protein shakes or smoothies. Sometimes, again, a smoothie may need to be room temperature. Most of the time, the standard over-the-counter nutrition drinks, they're shelf stable so that you can keep them at room temperature and the patient can take them. Make sure they're not cooled when they're having that really irritated area. It can hurt them a little bit more. Of course, taking your anti-nausea medications or anti-diarrheal medications as well can help with oral intake. How can we add calories to our diet? Really high calorie things. This is not the time to diet when you're having trouble eating. Granola, nuts, nut butters like peanut butter, using gravy or sauces, jellies and jams, honey. dried fruit if they can tolerate that, smoothies, nutrition shakes. You want a high protein, high calorie shake. You want your bang for your buck. Butter, margarine, or oil. Half and half, creamer to stews, soups, or hot cereals. Whipped cream or yogurt can be added to things to add more calories. Cream cheese or just regular cheese. If you're having mashed potatoes or potatoes that have been mashed up, you can add butter to them. You can add cheese to them. Just make them as high calorie as possible. Avocados have a ton of calories in them. Oil, hummus, mayonnaise, just really the foods that we may normally think of as not very healthy. They're healthy during this time because they're helping us keep our muscle. Adding protein to your diet. Meat, poultry, fish, soy, eggs, milk and milk product, whether it's yogurt, regular milk. There's a lot of protein. Cheese, there's a lot of protein in those. Nuts and seeds, peanut butter. Starchy beans like legumes, like you may have stews that have a lot of beans in them. They're very high in protein. Sometimes they can be easier to eat, whether there's altered taste or whether or not they're softer and more moist. Protein shakes, smoothies, protein bars, just anything you can to try to get that protein in them. So unfortunately, sometimes a patient just can't eat, especially through head and neck cancer treatments. You do not want to place a tube in a patient prophylactically for a number of reasons. The biggest reason is because a lot of patients don't need it. So you don't want to get them to go through a procedure that they don't really need. The other thing is that we want to preserve their swallowing. And if we want the patient to eat as much as they can during their treatment, because just like losing muscle on your body, your swallowing is muscle too. So we want them to use those swallowing muscles because they're going to want to use them when they're done, once they're done with the treatment. If you have somebody who needs a Dopphoff tube, which is a tube that goes into your nose and down to your stomach, that is a shorter term tube. We'll talk about that a little bit more in a minute. A PEG tube or a PFG tube is a tube that's placed endoscopically into their stomach, or they use radiographs to place it in the stomach too as well. That's more of a surgical procedure. Formulas may not be covered by insurance. And we're also going to talk a little bit more about hydration too. So when do you consider whether or not a patient might need a tube feeding? We say 10% weight loss, but it really is just a number out there. You really want to kind of look at your patient. If the patient is coming in and they're in week 1 of radiation and they can only eat 10% of what they normally eat, that person is probably going to need a tube because they just can't get past it. Because you have to think about radiation as like the time period that you get through the radiation. And then they're going to have about a month and a half where it's still very difficult for them to eat. So you have to think about that time period for a long time. If a person at the very beginning of their treatment is having trouble, that's going to be more of a surgically placed tube. If a person say they've gone all the way through their radiation treatments and they don't really feel their side effects until after they've stopped, which sometimes too, that happens too as well. And they're eating okay, but then they have a week or two that they can't eat anything at all. It may be even after they're done. A Dopphoff tube or a tube that goes in your nose down to your stomach can be used for a couple of weeks to up to a month just to keep their hydration and their nutrition status up. This is definitely a shorter term tube, but yeah, you can place it even after treatment has stopped. Insurance may not pay. I'm not sure how it is where you live, but they may not pay for the formula. It's okay to use over-the-counter products like Boost or Ensure. We'll talk about the selection of the formula a little bit on the next slide. Usually using syringe feed by gravity is going to be the best thing that you can do for the patient, where basically you have a 60 cc syringe. And when you're using the 60 cc syringe, you don't want to push the feeding in. Basically, you want to take that stopper out and pour and let it go to gravity. If the patient is holding it up, it's going to go to gravity. If they hold it down, all their stomach contents are going to come out. So you want to make sure that they have it up. You want to think about a slow pour, okay? You're not like really rushing that feeding in, but going really slow. Usually if a person is starting on a feeding, you want to start about a half a can at a time and go up about a half a can per feeding. That's a slower progression until they get to what they need. Now, you do need to consider about the fact that you want to keep that tube patent and open. So you want to flush with about a syringe full of water before, or 2 syringe fills before and 2 syringe fills after. That really helps to clear that feeding out of there. You want to be very careful with medications. They need to be, first, you need to make sure that they're a medication it's okay to crush them, but you want that solution to be really liquid before you put it in the tube, or else you're going to clog that tube. Flushing additional 30 milliliters of water before and after you give any sort of medication. So tube patency is really important. Proper flushing is the biggest thing that can help to keep that tube open.
Hey, Beverly.
Now, what kind of formula do you want to choose? You want to use a very concentrated formula, high protein, high calorie formula. Choose a formula like a Boost Plus, Incher Plus, or a generic Plus version is typically a more concentrated, high protein, high calorie formula. Most patients are going to need about 5 to 6 cartons. Obviously, a bigger person may need 7. A smaller patient may only need 4.5 or 4 if they're really tiny. If a patient has higher blood sugars, you may want to consider a diabetic formula. Just keep in mind they're going to need more of those because it's a lower calorie formula. You want to think about, in addition to what the number of cartons of feedings you're giving them, you're going to probably want to give them an extra liter of fluid daily per their tube as well. You can give it as a cup at a time, or 240 milliliters at a time. You can give it in between their feedings. And this is in addition to those flushing techniques that I talked about before and after the feeding. We already talked about overhydration or underhydration too as well, paying attention to those signs of symptoms of their urine output or their orthostatic hypotension, and looking at their skin turgor. Sometimes you can pinch it. If the skin stays up, they're going to be a little bit more dehydrated. Whether or not you use a fiber formula or a non-fiber formula, typically I tend to, in radiation, choose a lower fiber formula because a lot of times people may have a little bit more gas or irritation during their radiation treatment. Or if a person is not eating a high fiber diet and you start a higher fiber formula on them, their tummy is not going to be very happy with that. So keep that in
Beverly. Hey, Beverly.
Yeah.
There's a nice question in the chat. Alex said, how do you achieve fiber intake in a patient on a PEG tube feeding? Mostly blended foods destroy fiber intake. Any advice that you can give to that, or is that a myth, or what are your thoughts?
Yeah, so we're thinking about, on this patient population, we're hoping this is a short duration that we're having to give them a feeding. Pardon me. So we do want people to eat higher fiber diets for their health. That is completely true. But what you're trying to do here is you're trying to focus on their protein and their calorie intake. Okay. There are some formulas that are higher in fiber, but you have to be careful with those formulas because if a patient is eating a lower fiber diet, they're going to have their tummy be upset because they're not used to eating that. And that goes for anybody, whether you're on a tube feeding or not on a tube feeding. When you start to reintroduce fiber into the diet, you want to go slow because otherwise your tummy, you're going to have gas, bloating. You may have more constipation because your tummy's just, hey, what is this going on? So during radiation treatment, we're really much more focusing on trying to get in the actual nutrition. If we can do it with a higher fiber formula, that's great. But even if we're just getting a high protein, high calorie formula, this is good for the patient too as well.
Good. And there another question. I'm assuming they mean undigested. How can some undigested food be dealt with? Do we need to aspirate some undigested feeds before putting
Mm,
others
that's a
through the
great
tube,
question.
the
Yes.
stomach contents, right?
No, you do not want to aspirate out of the tube. You don't want to teach the patient to do that. You more so want to think about, there's been lots of studies that show aspirating the food contents out. Actually, all it does is it decreases the amount of tube feeding that you get in. It doesn't decrease the risk of aspiration or anything like that. Basically, if a person is not tolerating their tube feeding and they have nausea, vomiting, diarrhea, or something like that, you want to think about doing smaller volumes at a time. Maybe they need a pro-mobility agent. They may need to start on Reglan or something like that. But again, that's another reason to start slow and go up. That's a tolerance issue too as well. Maybe if you have a patient that's a little tiny patient and they can't take 120 milliliters before they're feeding, 120 milliliters after. Maybe they can take 30 milliliters before, they can take a can of feeding, and 60 milliliters after they're feeding. So you want to think
Right.
about volume too.
Right.
That's a really
And
good
I think
question.
And I think to hammer it home as a nurse as well, I've done this over 20 years, and Beverly can definitely do this. I think patients, once they have a feeding tube, think, like she said, I need to get this whole carton in one sitting because that's going to be the best. And one thing that she focused on in a couple slides ago, which I think really needs to be reinforced to patients, is once you give them that syringe, if you do not educate them properly, they're going to want to push because that's what a syringe does. And they're going to want to force that into their stomach. And I've had lots of patients call me that, oh, I immediately threw up. And when I was like, well, did you hang it by gravity? Did you, like we talked about, just pour a little bit at the time? And they're like, no, it was a syringe. I went ahead and pushed it. So I think reinforcing that can save a lot. And again, not everyone can handle the same formulas. You get some diarrhea issues, and that's where that open communication with your patients really comes into play. But yeah, I just wanted to reinforce that because, like I said, I've been on the phone call side of that where they're just pushing that fluid in because that's their nature with a syringe. But Beverly, someone asked about mango juice. What is your thoughts on doing mango juice?
Like through the tube
Not
or
sure.
just in general?
Let's see.
I'll talk a little bit about, in general, you don't want to put food or other fluids in a tube because of that patency issue. It has to be like so thin. Otherwise, you're going to clog up that tube. Sometimes patients are tempted to put regular food in there, but you have to think about the consistency being as thin as like a Boost or Ensure. That's really thin, and food is not really thin. And a lot of times they would have to thin it down so much, they're not going to get the actual nutrients that they need in the food themselves. But some people, they just want to have some food. So I usually tell them like clear broths. It's okay to flush some in there. Sometimes too, it's good for them to take some clear broth too. Maybe they have some sodium issues and need a little bit of electrolytes. You can add something like that. If they are having electrolyte issues too as well, or their sodium's really low, you can use Gatorade or other fluids like that too. It can help with their electrolytes. Okay, next slide. Okay, what are their take-home points? Are cancer patients at risk for malnutrition or poor outcomes? Yes, yeah, I hope that made that crystal clear to you. How do you know if a patient is at risk for malnutrition? You want to think about, can I not eat as much? Do I have signs and symptoms of malnutrition on me? Do I have symptoms that make it hard for me to eat? Have I lost weight? Those are risk factors for malnutrition. And do you think patients would benefit from nutrition intervention? Yes, yeah. You want to start at the beginning. I can't focus on this enough. Patients think that it's okay to lose weight. They think that, especially if they have some weight on them. And you have to start early at the very beginning. Don't lose weight. Don't lose weight. And sometimes even I say it in a different way because Sometimes people want to lose weight, and we get that. Say, we do not want to lose muscle. That's the weight that we don't want you to lose. We want you to keep that muscle. It helps with your quality of life. It helps you to rebound, to be able to get your treatment. It helps to heal. All of those things, maintaining your lean muscle mass is really important to do.
Speaking of that, Beverly, I think at the beginning you talked about cachexia, and someone asked, how does one, this is probably a loaded question, how does one improve nutrition in someone who is cachexic?
Yeah, unfortunately, most of the time you don't.
Yeah.
It's really terrible. That's why we focus on nutrition so much at the beginning, because it's a spiral. Once the weight loss happens, it just spirals down, and it's it you don't, most of the time they don't recover from like a cancer cachexia. Now, if you're in a curative sort of treatment where they're getting chemo rad for like head and neck, sometimes they're in a state of, they're in a more of a catabolic state, which is not the same as a cancer cachexia. A catabolic state is just basically where you're burning. You're not able to rebuild at that time. What you'll see with those patients, like after they're done with treatment, it'd be maybe a month or two, they may still not be gaining weight or lean muscle mass, but at some point they'll get over that hump, and then they'll start. And they're going from a state of being really inflamed to a state where they're able to build back again. So again, yeah, you want to try to stop the weight loss as much as possible, because once they're cachectic, they don't gain weight and they have poor outcomes.
And I think it's very important as nurses that we celebrate the small victories. In my practice, I see patients 3 months out who finally starting to add some food maybe in, and they feel much better, they're getting better, and then they get disappointed that they only gained a pound. But you always got to say, you're not going in the other direction. You can show them the trend and like, look how weakly you were when you finish. Look at this long trend, and now you're starting to even out and slowly gain it back. So it's just giving them hope and really celebrating those small victories. I'm sure Beverly would agree is
Oh
the
yeah.
biggest thing. Do not get disappointed that you gained only a pound. A pound is a pound. You're going in the right direction. And they're going to have these roller coasters post treatment. And I've had patients, like Beverly can probably assume, that they want their peg tube out as soon as
Yes,
they start adding
immediately.
oral
Yeah.
nutrition. I'm like, wait a minute, you've had one good day. It does not
Yeah.
mean you need to take that tube out.
Yeah.
And my doctors will usually want them to have a good couple weeks of 100%
Yes.
oral intake with no
Yes.
setbacks, because these patients are very tricky and they will
Mhm.
have setbacks. It's just almost expected. And at the end of their treatments, I like to prepare them for that and be like, yeah, you're sick. You could be 6 weeks out and you could still have a setback. But guess what? That feeding tube is still in place and it's there for a reason, instead of putting them back under surgery and trying to do it that way. So someone did ask, is there any best way that you can manage cachexia? That seems to be a routine question that they're having. They must see that a lot. That's a
Yeah.
loaded question.
Yeah. So it's starting earlier
Right.
before it starts. It's really concentrating on making sure they don't get cachexic in the first place. Okay. Because weight loss is the route to cachexia, basically. So at the very beginning of the treatment, really focusing on maintaining that weight and lean muscle mass. Okay. And again, in practical terms, it's making sure that you're consuming enough calories and protein. Okay. And choosing those things where you're eating a protein with a carbohydrate or fat. So you're using that protein for your lean muscle mass, and you're using the fat and the carbohydrate for energy sources. That's the biggest way. The biggest thing to help with cancer cachexia is to not get it in the first place.
And Beverly, what if you're a nurse and you're meeting the patient for the first time and they're already cachectic? Then what should you do?
Still, again, just making sure that you're encouraging protein and calories, very high protein and calories. It's not the time where you're having a person A lot of times when people first get a cancer diagnosis, they're scared to death and they want to do anything that they can to help themselves. So they start with their diet and they're like, I'm only going to eat organic food, fresh fruits and vegetables, and anything like that. And you are really focusing on the fact that starting with that patient, that you are telling them to make sure that you're eating high protein, high calorie foods because we're trying to maintain that lean muscle mass. Calorie and protein needs are really higher, much higher than like the normal person are they're going to be. And also too, their capacity to eat is likely very low. When you see a person at the very beginning that may be a little bit cachectic at the beginning of their treatment, it can be a couple of reasons why that's happening. Sometimes they just have a cancer that's just hypermetabolic, and it's going to be very difficult to get that person to gain weight and still until they've started their treatment and their cancer is being taken care of so that the body can actually rebuild itself too. Or you may have a person who's obstructed, whether it's swallowing, that sort of thing, that they just can't eat enough. Again, you may want to, if a person who has come in and they're a head and neck cancer patient and they're going to need a surgery to get them started, a lot of times they'll place a tube prophylactically or basically in them during surgery because they're going to need to eat that way. So really, again, starting at the very first, high protein, high calorie. If they can't do it through their foods, adding in oral nutrition drinks or high protein calorie snacks, those sort of things are really going to help the patient to the extent, but you can almost not get enough in them.
And someone's asking, I think we know the answer to this, is it safe to advise patients to avoid sugar and sugary diets?
No, it is not safe for that. A lot of people think that's true. Unfortunately, we can't starve cancer without starving our own cells. Cancer cells are smart. Our cells are smart. What happens basically when you're avoiding sugar or carbohydrate in general, what happens is that you still need carbohydrate and sugar for energy. All cells do. Our healthy cells and cancer cells need it as well. And when you take away carbohydrate from the body can still create carbohydrate. It just creates it out of fat and protein. And it almost always uses your uses your lean muscle mass to make that sugar. So you can't bypass that. You can't hack that system at all. So really you are not encouraging people to not eat sugar, especially people who can't eat. Now, if you have a person who they can eat a healthy diet, like an anti-cancer diet, and they don't have any trouble swallowing or they're not having any side effects, and you want to promote a healthy diet, that is a diet that's not high in processed foods, a high leaner meats, or high protein vegetables, lots of fruits and vegetables that have phytochemicals. They have vitamins and minerals in them. That is like what is an anti-cancer type diet. But when you get to the point where you cannot eat, you cannot bypass that. You want your doctor to, whatever they're doing, whether it's radiation or chemotherapy, to take care of the cancer cells, and you feed yourself so you can rebuild your own cells. So it's not the time to diet. A lot of people want to diet when they get a cancer diagnosis because they're very scared. They're scared to eat sugar. Everyone will ask that question. I do not think I have had one person who does not ask that question. It's very common. But yeah, you can't bypass that.
Good. And this is a really good question that I'm actually interested in your response. What advice would you have for cancer patients who are vegan?
Oh, it's fine. They can be
Yeah.
vegan. It's no
Any
problem at all. Again, your body can make things out of that. You usually have to supplement B12. They've been vegan for a long time. They may have some iron deficiency too as well. If those are, or if you're deficient in them, they may need to be supplemented. But protein is in everything except for fruit. Protein's in all vegetables, all grains, it's in beans, legumes. It's completely okay to be vegan. And there's a lot more protein shakes out there that are vegan too as well. There's even, and I'm not sure what all is available in your area, but there is a vegan tube feeding formula that I use a lot that I like. It's called Kate Farms. And basically, it's a really good formula that's more plant-based and it's vegan. It also is void of most allergens too as well, but I use it in patients a lot. They tolerate it well, unless it's a patient who doesn't eat a lot of fruits and vegetables. And if I start that on a patient like that, their tummy gets upset and they're like, they have a lot of gas because they're not used to eating a lot of fruits and vegetables. But there's a lot more options out there now for patients who are vegan. But yeah, you can meet 100% of your needs through a vegan diet. Okay, I want to go over my reference slide. The first three are just different articles. These are good websites to look at too as well. Oncology for Clinical Nutrition Practice is a book that you can look at that goes over different things. If you have membership to the Academy of Dietetics, or you can sometimes buy online care manual that you can print education material on there too. That's an option if you have that available to you as well. The different screening tools that we talk about. But here are also different websites too as well. Eatright.org is the American Dietetics Association. American Institute for Cancer Research is really good too as well. They have a lot of great recipes and resources on there too. This is the MD Anderson recipe website too. It has a lot of great recipes in there. And we're a multicultural. We have people all over the world coming to MD Anderson. So there's a variety of different recipes on there too as well. The British Association for Parenteral and Enteral Nutrition have a lot of those screening tools available on there as well. And the American Society for Enteral and Parental Nutrition are really great sources too as well. Were there any other questions?
Beverly, I wanted to thank you and John both so much. What you shared today is essential wisdom that we as nurses can apply for any patient that you see. That's what's so powerful about nutrition is that, yeah, every patient that you're seeing, you have the opportunity to make a difference. You may be the only one on the team who's focused in on what are those physical signs that there could be a malnutrition, and you have the space to be proactive and help those patients avoid falling into a hole. I'll tell you, as a radiation oncologist, I'm often focused on other things. I may not
Yeah.
have time to focus on nutrition, or it may escape me. And I also may not really know as much. Even though we're doctors, we don't have as much education about nutrition. As nurses on the team, if you can become experts, ninjas at nutrition and figuring out how to help every patient in their own way, you can make a really big difference. And remember, I think the most important role as a radiation oncology nurse is helping your patients successfully finish their treatments.
Right.
And that protein, every 24 hours in between each treatment, their body is working, the normal tissues are working on healing.
Right.
And so you have a patient who has protein, they're going to be more likely to have less side effects and get through that treatment smoothly. Yeah, thank you so much. This is really important.